Hey everyone, welcome back to Nurse Crit. My name's Chasen. I'm an acute care nurse practitioner. Normal saline? Lactated ringers? Which one is better? Does it even matter? You might be thinking that this is a boring video topic, but there are actually some intellectuals who have entire debates over this subject. Are you Team NS or Team LR? Let me know in the comments. The objectives for this video are to review the composition of each crystalloid, understand some of the notable physiologic effects, and identify when to choose one fluid over the other. Normal saline and lactated ringers are both IV crystalloids. They are both sterile solutions that contain various electrolytes and are used for volume resuscitation in patients who are hypotensive. The reason these are the two main resuscitation fluids are because they are considered to be isotonic. Their solute concentration is relatively close to that of human plasma. If you have seen my other videos, you may recall that the normal serum osmolality is about 280 to 300 milliosmoles per liter. When crystalloids like NS and LR have a similar tonicity as blood, there is much less fluid shifting, which is important when you want fluids to stay in the vasculature. So if both fluids are isotonic, does it even matter which one we choose? Well, let's first examine the constituents in each solution, and then we can extrapolate some of its effects in the body. First, we have normal saline. It's pretty straightforward. It only has sodium and chloride. It's nothing more than salt water in a bag. Probably not until a decade into nursing did I start to examine fluids a little more closely. I didn't make the effort to memorize it, but I want you to remember that NS has 154 milliequivalents of sodium and 154 of chloride. Now, referencing back to my video on the basic metabolic panel, you know that the normal serum sodium level is 135 to 145, and the normal chloride is 98 to 106. So compared to normal human plasma, NS has too much sodium and way too much chloride. Next, let's compare the composition of LR. It has 130 milliequivalents of sodium, 109 of chloride, 4 of potassium, 2 MEQs of calcium, and 28 MEQs of lactate. Here, the sodium is slightly less than plasma, the chloride is barely elevated, and the potassium is within the normal range of 3.5 to 5. We don't typically measure the calcium level in milliequivalents, we usually report it in milligrams per deciliter. But if you were to measure in milliequivalents, the normal range is about 4.4 to 5.2, so the amount of calcium in LR is less than half of the serum level. And a normal serum lactate level is less than 2, so there's actually a lot of lactate in LR. Now that we know the chemical composition of each fluid, let's look at some of their effects within the body. The first principle to understand is the law of averages. Whenever we introduce a solution into the body, it is naturally going to average out. For example, let's say that we have 5 liters of blood and our sodium level is 140. If I give 1 liter of NS, my new serum sodium level should average out to be 142. Because the NS is more concentrated, it's going to make my serum sodium more concentrated with each additional liter. But if I could theoretically give 100 liters of NS, my sodium would never go higher than 154 because that is the maximum concentration of the fluid. 1 liter of normal saline gives us a very small 2-point increase in serum sodium. But what about chloride? Let's take the same person whose blood volume is 5 liters and their chloride level is normal at 98. If we administer 1 liter of NS, the chloride should bump up to 107, which is a huge 9-point leap. It doesn't take that many liters of NS to really raise the chloride. And if you watched some of my other videos, you know that when the chloride goes up, the serum bicarb reflexively goes down, creating a hyperchloremic metabolic acidosis. This is one of the main consequences of giving too much normal saline. It's unclear how consequential this acidosis really is, but in general, we don't like to have any acidosis in the body. Acidosis tends to disrupt many enzymatic functions that are necessary for normal physiology. Acidosis can also cause potassium to diffuse out of the cells into the plasma. The last main concern about excess chloride from NS is acute kidney injury. High chloride levels affect the kidneys via multiple mechanisms, but one of the main causes is vasoconstriction of the afferent arterioles. too much NS can trigger a decrease in blood flow and therefore decreased glomerular filtration. Unlike normal saline, lactated ringers does not significantly raise the serum chloride, so it does not produce an acidosis. In fact, the lactate in LR is metabolized in the liver to generate additional bicarbonate ions. So LR tends to have an alkalinizing effect, or at the very least, a neutral effect on the pH. Lactate may also have the benefit of providing energy to the heart and other organs in need. Psst, check out my previous video on lactate. One of the common circumstances where physicians tend to avoid LR is in hyperkalemia because there is potassium in LR. However, going back to the law of averages, we can theoretically give 100 liters of LR and the serum potassium should never go higher than 4. So giving LR to any patient with hyperkalemia should actually lower their potassium level by diluting it more. Now, I understand this is only theoretically what would happen if humans were test tubes, because there are other variables that can alter this law of averages. Because potassium can shift in and out of cells, and because the kidneys can excrete water and reabsorb potassium disproportionately, the law of averages may not always hold true. In general, lactated ringers simply has a composition that more closely resembles human plasma, which means it is less likely to create additional problems when used for resuscitation. So given these properties of each fluid, and with an increasing amount of evidence over the years, lactated ringers seems to be the superior solution in most situations. LR should probably be your default choice when resuscitating a patient with sepsis or DKA or other hypovolemic states. Even in patients with hyperkalemia, LR is not automatically contraindicated. In fact, although NS has no potassium in it, if it creates a significant enough acidosis, it can cause a worsening shift in potassium, which is counterproductive to the reason it was selected in the first place. So in theory, LR is the better choice in hyperkalemia, although I would use it with very close monitoring in case theory isn't matching with reality. Although I stated in the beginning that both solutions are regarded as isotonic, NS is technically slightly hypertonic, and LR is slightly hypotonic. But each is only very slightly out of the normal range. Given that LR is slightly hypotonic, it may be less ideal in traumatic brain injury or any brain pathology in which giving hypotonic solutions may worsen cerebral edema. The other situation in which NS is preferred over LR is in states of hypochloremia, which can occur with excessive vomiting or NG suctioning. These are some of the very few situations where NS is actually preferred over LR. In virtually every other scenario, LR is going to be the better choice. Like everything else in medicine, even fluid selection is highly nuanced and requires thoughtful clinical decision-making rather than just a mental reflex or personal preference. This entire debate is probably a bit overblown, so in an emergency, don't quibble over which one to choose. Just use whatever is most readily available to you based on your circumstances. So are you Team NS or Team LR? The correct answer is neither. There are no teams, only clinical situations. And now that you know the appropriate uses for each, you can say, hey doc, can we switch the NS to LR instead? Just as a reminder, this topic, as well as many others, can be found on my Instagram page. Everything there should only take about a minute to read. Before I ever created my first YouTube video, I vowed to myself I would never ask anyone to click the like button or subscribe to my channel. But then I unfortunately found out that that's exactly what YouTube wants and encourages and rewards. So I really hate asking each time, but please like, share, comment, and subscribe to help this channel reach more viewers who can benefit from additional nursing education. Thank you so much for watching, and I hope you learned something useful for your practice. See you all next time.